Hello, everyone. Today's topic is going to be pericarditis. What are the CCS orders that we will be placing? We're going to discuss the treatment, the orders that you might want, and so on. So, stick with me throughout this video. Firstly, please remember pericarditis is something we just have to diagnose, okay? They will have chest pain. Now, anytime if a patient walks in with a chest pain, all you can do is the basic tests. And basic tests include CBC, BMP, chest X-ray, okay? Chest X-ray. I don't know why this is being written this way. I hope it makes sense. So first we're going to do chest X-ray and then we will do echo. Okay. And this one, make sure you want to do thoracic echo because this is the one that gives you a good overview of heart. Okay. And then we are also doing pulse oximetry. Pulse oximetry. Troponin levels. See, these are 4 different tests for patients with chest pain. Now, anytime, whatever the pathology is, okay, regardless of who you are dealing with, these are the basic tests for a patient generally presenting to us with chest pain. What are the causes of pericarditis? Let's move on to this topic. The causes are very few, one of which is autoimmune. This is the most common cause in US. Okay. In India, it used to be TB, whereas here it is autoimmune. And then there can be several other causes like viral causes. Okay. Viral causes. And then there is one more thing that can predate pericarditis, and that is thyroid levels, thyrotoxicosis, yes. So make sure you include these basic investigations in the order. Okay. Soon after the patient presents with pericarditis, what would be the treatment? Now let's move on to our essential component of the video, and that would be treatment. So in terms of treatment, let me simply write down here in this small little circle. So treatment is going to be pretty straightforward. Okay. Firstly, we will do steroid, NSAIDs. I'm sorry, it's NSAIDs. Okay. Anytime you're dealing with a pericarditis patient, NSAIDs. However, if there is a post-infraction pericarditis, meaning just before Dressler syndrome or something like that, you do not want to do NSAIDs. And what is the reason? The reason is this can block the healing, resulting in impairment in the collagen formation or the scar formation. Okay, so that is one of the exceptions that you might want to remember. In this scenario, we will do NSAIDs, and the preferential drug that you can think of could be, I don't know why it's acting weird today. There is no scope of changing the colors. I don't know. Maybe let's see. What's wrong? So you want to give NSAIDs, give celecoxib, and here you're going to give the celecoxib in a very large amount. It's going to be high dose. Okay. Uh, this is the one that has to be given. Now, when you're giving celecoxib for a higher doses, it is always important to think about um, something like a GI pathology. There is increased risk for ulcer formation. Okay, in order to avoid this, give pantoprazole. I'm not sure if this makes sense. I'm sorry for the writing part today. I don't think it is very bad and good enough. Mm, okay. So let's just continue on this one. With along with celecoxib, you want to give pantoprazole to the patient. Celecoxib and pantoprazole. Along with this, there is one more drug that needs to be given, and that is also equally important, which is colchicine. See, just remember C's for C's. You're giving C drugs here, okay? Colchicine and celecoxib. Why do you want to do colchicine? It is to prevent the recurrence of the pericarditis, okay? To prevent the recurrence. After this, all we can do is wrap up the case with some solid advices. In the advice list, do remember to ask the patient to take rest following the episode. Okay, because any kind of activity can literally potentiate another attack or recurrence. So patient has to take adequate amount of rest before anything else. And one more important thing that I would want to address at this point is that um, patient would walk in the ER, okay, and you give all this. Immediately, the patient might feel better. So, this is usually treated on outpatient basis. Outpatient. You don't need to have to admit this patient. Kindly note this point down. I mean, there are so many errors that we may want to um, overlook, but this one is something very important, I believe. You have to have this trick of shifting the patient depending on the scenario. So please do not admit these patients right away. It is treated on outpatient basis here in US. And then what else? If the trial of NSAIDs is a failed, okay, let's say if it is failed, then what is the next? What is the other drug that you might want to remember? It is glucocorticoids. Glucocorticoids. Okay. So this is it, guys. You don't need to do a pericardiocentesis. You don't need to do any invasive techniques. Okay. Now, when do you do pericarditis? When the on the echo the effusion is over 2 centimeters. Okay. Then you can do pericarditis. So, in the chest pain, if if a patient has a chest pain, there is a list of TDs that you might want to remember. Again, it can be esophageal esophageal spasm, gastritis, GERD, MI, or pericarditis, aortic rupture, right? So when you remember these causes, it becomes very easy to literally cramp down every single orders. But then I emphasize again to make a checklist of investigations with patients having specific symptoms. This is the checklist here. Okay. Now that should be clear enough. I hope it does sound logical for you to get started with the CCS preparation. And I wish you all the best. Thank you for watching. Bye bye.